So now we're just going to quickly look at anger, aggression, and violence. These are problems that can occur with people that have schizophrenia. Of course, it can also occur in any setting in healthcare. So it really is something that nurses need to pay attention to and something that we really do need to actively intervene in. So chapter 27 in Varkarolis is where we're at. So just anger is an emotional response to frustration, of desires, threat to one's needs, emotional or physical, or just a challenge. So we've all, I'm sure, dealt with anger, and sometimes it can be very disconcerting, very uncomfortable for us to deal with anger, and we may feel very intimidated, or we might even feel very defensive when patients or visitors are angry. So it's good to kind of think about how we can more appropriately deal with those types of issues as a nurse. Aggression, then, is the action or behavior that results in a verbal or a physical attack. So, really, aggression can be verbal or physical. So, epidemiology in the hospital, violence is the most frequent in psychiatric units, emergency departments, and geriatric units. So I wonder if any of you are surprised by that, or maybe you're thinking, yep, that's just what I would expect. And that's not to say that it can't happen on a medical unit, a surgical unit, in the operating room, in the PACU when people are coming out of anesthesia. It certainly can happen almost in any setting. But I would have to, just based on my own experience as a nurse, I would say, absolutely that this is pretty accurate. So if the geriatric unit, if that surprises you, maybe you have never spent that much time in a nursing home, but honestly, people that are elderly, and especially people that have dementia and their behaviors are very disinhibited and impulsive, boy, can really have a lot of violent behavior. So unfortunately, violence is an issue that nurses need to deal with. Comorbidities. Many times people that do have PTSD are prone to violence, substance abuse disorders, and that can coexist with depression, anxiety, psychosis. Again, I want to stress that people with schizophrenia usually are victims of violence, but if people are really paranoid, that can predispose them to violence because they want to hurt the other person before they get hurt. So that might predispose somebody to act out in a violent way that has schizophrenia. So, and then if people have personality disorders also, they just don't have the resources, sometimes the internal coping resources to handle conflict and difficult situations in a very, productive manner. So I guess I could say that there was once, it wasn't that long ago. I think it was maybe about a year ago or so, where I was actually trying to take a group of students on a tour of the unit for intermediate clinical, and I was told, no, don't go out on the unit just yet. So I had to kind of stall behind closed doors and talk to the students about something else. And then finally they said, yeah, the patient went down to her room. We think it's okay. You can come out onto the unit and start your tour. Well, I was probably doing about 5 minutes of the tour, and all of a sudden, one of the nursing assistants comes running up the hallway screaming, call the police, call the police. So at that point, I took the group of students and had them go into a large walk-in shower and locked them in because I wasn't sure what was going on, and I just kind of assessed the situation. And when it was safe, after the police arrived and they had things calmed down, when it was safe, then I let the students out. So that was kind of an unfortunate situation. What an introduction to the mental health unit, and it might have made a few people, a little bit scared to be on the unit. But quite honestly, yes, people that have mental illnesses certainly can act out in a violent way. However, it's not like it's a battle zone and it's a constant, situation. And certainly nurses can intervene before the crisis occurs. And that's kind of really the whole point of talking about anger, aggression, and violence in nursing, is that if we really can try to work very hard, we can, to head this off at the pass, then perhaps those situations aren't even occurring. So, and that's not to say that that we're to blame if situations do get out of control. and that it's our fault. It's not for that, but it's just a matter of, let's try to work on ways as a profession to try to handle situations perhaps differently that might make people less prone to violence. So, and the person that was acting out definitely had a personality disorder. She was not psychotic, but she was really very violent, and she actually ended up hurting a couple of staff members. So that was really, boy, just not a good situation at all. But again, something that we have to deal with. Of course, there are a lot of controversies, a lot of opinions going around, especially lately, because there have been some incidents of violence that have been really extreme and have made the news, national news. So it is something that nursing is looking into, and we really do need to band together as a profession and try to work on this issue, because we shouldn't be just accepting that violence is part of the job, and it's something that if you get hurt or you get physically attacked, verbally attacked, that it's just okay and part of the job. Really, we should be really trying to work on this, and patients should not be hurting us. And yeah, we really have to work on this as a profession. It's kind of beyond the scope of this learning plan as far as, what actions really need to happen. But I'm just pointing that out as something to for the profession of nursing to work on really in the future. So again, we're always using the nursing process when we're assessing a patient's potential for violence. So we're doing a general assessment. We're always looking at trauma-informed care. If that person has a history of trauma, they absolutely are going to react to situations differently than the person who has not been a victim of trauma and or abuse. So we have to take that into consideration when we're performing their plan of care, and we have to intervene in a way to really make them feel safe. Self-assessment, again, we have to deal with our own thoughts and feelings about violence, because it can be very unsettling and very nerve-wracking to try to take care of these types of situations. So, case study on the behavioral health unit: Mr. Oswald's paranoia is continuous, and he becomes agitated and threatens to assault a staff person. He tells you, "You're the only one I think I can trust, but can I? Are you going to take their side?" So that would be a kind of a difficult thing for a patient to say, because, of course, you are tempted to say, "Oh, no, I'm not going to take their side. I'll be on your side." But that's not really necessarily very therapeutic. We can't say things against other staff members just to try to gain a patient's trust. So, you have to say something in a general way, as in making the patient feel comfortable with you, but you certainly don't want to make the patient um, feel like you're in it together and you also are against the other staff members. So you probably want to say something therapeutic like, "I can see you're having a really hard time right now. You absolutely trust me. I hope you can trust me. I am a trustworthy nurse. I'm here to help you." And just to say something like that, and just not even to respond directly to that aspect of, "Are you going to take their side?" Just kind of, I wouldn't even respond directly to that. So, audience response question. Select the best initial intervention for Mr. Oswald. Say, "If you don't calm down, seclusion will be needed." Address him with simple directions and a calming voice. Help him focus by rubbing his shoulders, and offer him a dose of antipsychotic medication. So I'm hoping that you are thinking that the first thing that you would do, the best initial intervention, would be simply to address him with simple directions and a calming voice. You definitely don't want to do A, because even though that might happen, you don't want to ever tell somebody to calm down. It is the most untherapeutic thing to say, to tell somebody to calm down. So, matter of fact, they're really stressing that and teaching that when they're doing violence intervention types of programs. So we never want to say that, and we never want to threaten them with seclusion. And helping somebody focus by rubbing their shoulders, we absolutely do not want to put hands on a patient when they're angry and upset, because they may feel that that is a threatening action on your part. So you don't want to put hands on somebody. Offer him a dose of antipsychotic medication. While that's not the worst thing you could do, it's actually something you might do eventually, but not the very first thing that you would do. So you might do that next. That might be your second intervention. So, discussion question. A new nurse asks a coworker which patients are most likely to become angry or aggressive. So, what are some risk factors that may predict violent behavior? So, again, besides having different types of mental illness diagnoses, the other thing that's a huge risk factor is simply previous history of violent behavior. So if anybody has any kind of previous history, that we need to take that seriously and to jot it down, write it down somewhere, and to keep talking about it. Again, I think I mentioned before that they do like a safety huddle now on 1K where they talk about and highlight before report starts different patients and some of the their violent history. If they have ever hurt staff, if they have thrown objects, any type of violent behavior is well documented and brought up at each admission. And that's not for, shaming the patient or for, adding to their stigma, but it's really just for staff information. If we know who has a history of violence, then we can hopefully prevent that from happening. So just some other things to look at, just some basic signs and symptoms that somebody is getting upset and agitated. And I would bet that you would be able to figure out just by looking at somebody's behavior and their affect. You can tell if somebody's getting worked up. So I had an incident a few years ago too, where students were kind of watching on a camera. They're watching a particular patient, and they could tell that something was going to happen. They were all watching in the back room and watching the camera and seeing the patient get up, sit down, take their sweater off, put it back on, get up, wring their hands, pace around. It's like we could all tell something was going to happen. And yes, definitely that patient at one point then burst out of the room and tried to run down the hall and escape out of the unit. So, we can see it coming. The look on their face, clenching their fists, unclenching, their eye contact. Sometimes it can be staring, it can be glaring. We can tell a lot just by looking at somebody's eye contact. So we always have to look at verbal and nonverbal behaviors that might predict that violent behavior. So some nursing diagnoses that might apply to some patients that are having these issues, certainly they're not coping effectively. They may be in stress overload. They have risk for self-directed violence and, of course, risk for other directed violence. And we always want to look at outcomes. So what are some appropriate goals that we would want for that person who has a potential for violence? So two things I want to point out. On page 507, there is a box, a green box called, that's 27.1, predictors of violence. So it would be good to kind of look through those, because those are things that are, again, symptoms. They're not always there, but they kind of can precede that violent episode. So some of the things I mentioned are on that list. And then the table 27.1, which is on page 509, and that's some signs and symptoms, nursing diagnoses, and outcomes for aggression. So really, it's always a great outcome if the person is able to identify when they're angry, identify alternatives, maybe express their anger verbally instead of physically, not invading other people's space. They express their feelings appropriately. They refrain from self-harm and harm towards other people. They're able to use their support system. So some really good ideas for you in terms of outcomes that we're looking for. And the implementation are the interventions that we're doing. So we're doing psychosocial intervention. So the whole way that we interact with a patient, considerations for staff safety. We always want to make sure that we're safe. Pharmacological interventions, of course, we can use PRN medications for that patient. It is always helpful to offer a medication, but the first thing always is, the way that you talk to and approach the patient. And certainly as part of your ongoing conversation with them, it's helpful to offer them a PRN and just say, would that be helpful for you at this time to take a Xanax or to take a PRN of their antipsychotic that would help them to calm down. Page 508, the psychosocial interventions, considerations for staff safety, and then pharmacological interventions on page 509 are really very, very well outlined. So again, the biggest psychosocial intervention is to create that therapeutic bond with a patient. Let them know that you understand what they're going through. So if you just say something simple like, boy, I can see that you're really upset right now, right away they know that you get it, that you are seeing that they're upset. And that's really the best first intervention that you can do. So you've really accomplished something great. And you can also state some expectations, like they say in the book. I expect that you will stay in control. So just making sure that we kind of tell the patient that we think that you can do this, and try to help them. And you can even say, I'm going to help you to stay in control. I'd really like to support. I can see you're upset, but I'm going to try to support your staying in control. Sometimes, though, behavior escalates really quickly. Somebody may have missed some early signs of distress. So honestly, there are some times when people just don't respond to those early interventions, and then violence arises. So, but we hope that, we always hope that we can intervene quickly. So we want to approach somebody in a very controlled, non-threatening manner. We have to make sure that we express that we're caring about what they're going through. If we're afraid and we're showing the patient that we're afraid and anxious, that certainly isn't going to make them feel any calmer. So we have to maintain that calm exterior, kind of no matter how you feel on the inside. And that is certainly something that kind of comes with experience. So the other thing to think about is personal space. So somebody who's at risk for violence really truly needs a lot more personal space. So we cannot be invading people's space. And we always want to make sure that we have an escape route if necessary. So we don't want to box the patient into a corner. We want to make sure that they can get away from us if they need to. So that's just super important, not to make them feel like they're trapped and they're in a corner. You also have to keep in mind that when somebody's really angry, their ability to process information really decreases. So we have to really, again, choose our words very carefully, speak very slowly, and the more controlled behavior we have, the better. So we just really want to model that for the patient, that we are in control. And we're going to try to use open-ended statements and just, again, really make sure that the patient understands that we get where they're coming from. So we want to try to find out what's behind their feelings, and then also we can try to give them some choices sometimes. The example they give in your book is, do you want to go to your room or to the quiet room for a while? So this helps to decrease their sense of powerlessness. It gives them that sense of control that can help them to avoid a violent episode. We do have to pay attention again to the environment. So choosing a quiet place is better, but we also want to make sure that other staff are around us. We don't want to ever be in a situation where we're down the hallway by ourselves in a room with a patient who is escalating and nobody knows where we are, and it's you're out of earshot of most of the staff, so nobody else can come to help you if you should happen to need some help. So very, very important. And considerations of staff safety, there are things that we should always be doing as nurses. Now, in the old days, we used to wear street clothes, and so many times we would wear jewelry, dangly earrings, necklaces, belts, all kinds of things, high heels even, I remember. Oh my goodness. So those days are gone, thank goodness. So now people are wearing scrubs. But I still see some staff members wearing dangly earrings sometimes. So not a good thing. Nothing. We really should be wearing absolutely nothing around our neck. No necklaces, no dangly earrings, because sometimes patients get focused on those and they may grab at those, causing some serious injury. Make sure we have enough staff for backup. Only one person should be talking to the patient. Because again, think about if you have schizophrenia and you aren't able to filter out multiple stimuli, then it may be really difficult for that person to stay in control. Know the layout of the area, kind of know where furniture is and different obstacles. And it's always helpful if somebody kind of manages the milieu and watches what's going on on the whole unit while a potential incident is taking place. We really want to watch our nonverbals. We don't want to stand directly in front of the patient or in front of the doorway. Again, we don't want to make them feel trapped, and we don't want to be in a confrontational looking position with our nonverbal behavior. Again, we can give them some feedback. You seem to be very upset, and that again acknowledges the patient's feelings. We might be able to verbally de-escalate the situation. So again, we don't want to confront, but we might have to have a show. They call it a show of support with security guards. It depends on the situation. I've seen sometimes that staff will have security stand like way up the hallway, like far away from the situation, because the presence of security might make the patient worse. But of course, you want security available readily on the unit if a situation does escalate to the point where their help is needed, so that nobody gets hurt. But it may not be the best thing to always have security right there with you. But in other situations, maybe the patient would respond better to somebody in uniform, and they actually would get control of their behavior, perhaps by seeing that patient in uniform. So you know what? It really is very individual. So in the book, it kind of says that a show of force by security may serve to escalate the patient's behavior. Again, it might in some situations, but some people actually respond positively to that uniform. So it really depends on the patient. So on page 509, there's a nice box, 27.2, de-escalation techniques. Again, just kind of a real nice summary of what I kind of talked about. Avoid arguing, giving them some options, making sure that we really want to maintain their self-esteem and dignity, because certainly that loss of dignity or feeling like you're just powerless can precipitate violent episodes. So we do have to really think very carefully about our behavior. So read through that box. It is very helpful. So pharmacological interventions, it's certainly appropriate to offer a patient a PRN medication. And usually we use that in conjunction with our psychosocial. So we start with the way we address the patient, and then we may offer them an antipsychotic medication or an anti-anxiety, depending on what's ordered for them, and that can help to decrease their anger and aggression. So, and in your book, many of the medications that we really just talked about earlier in the learning plan are medications that we might use, or even that we talked about in the anxiety learning plan, like Ativan, sometimes Xanax, Valium. Those types of medications could be used. Haldol might be used. First generation antipsychotic, Thorazine. Second generation antipsychotics, Risperdal for sure. Zyprexa Zydis, which is a orally disintegrating formulation of Zyprexa. So it just disintegrates on their tongue, and that can act kind of quickly. So sometimes patients use that when they're feeling upset. Geodon. The only thing with Geodon is you do have to, again, be cautious with that QT prolongation. And Geodon actually, when you have to reconstitute it, it's a little bit it's a little bit of a process. It's kind of, it's difficult and time consuming to reconstitute the Geodon appropriately. And so I've seen nurses standing in the medication room, shaking that vial, for a couple of minutes on end to get it mixed properly. And you know what, in an emergency situation, maybe that's all you have ordered, but to me, that's kind of a problem if you have to stand there shaking something for a long period of time while somebody is on the verge of a violent episode. So anyways. So, audience response question. Mr. Oswald becomes increasingly agitated when you come back from break. You find out he wants to talk to you alone. Your response is to respect his privacy and see him alone. Do not speak to him in private. It's time for the team to confront him calmly as a group. Ask for him to be put in restraints first, or take security staff with you, or go speak to him in a non-confrontational way, but ensure that there are other staff nearby for backup. So probably I'm hoping that you're picking D, because just approaching him in a non-confrontational way, making sure other staff, or even you could make sure security was there for backup if you really felt like the situation warranted that. So the nursing process, again, we're always, after we make our assessments and plan, we implement. So we are doing our interventions, health teaching and health promotion. Of course, we can't really work on those types of issues until the patient is in a calmer state. So that's not something that we do when a person is in an acute agitated episode and they're on the verge of violence. Not really the time for health teaching. That should be done perhaps after the incident. And you know what? A debriefing type of situation is always very helpful for the patient to kind of review with them what happened, how are you feeling, what caused it, and what could you do differently the next time to avoid the violent episode, if they end up actually losing control of their behavior. But also just general things like not using nicotine, not using caffeine, things that are going to increase their agitation, certainly not using drugs and alcohol. All of those types of things would be very helpful for them. And just basically reviewing with them coping mechanisms, self-soothing skills to manage their own behaviors and feelings are very helpful. Case management. So sometimes patients might have chronic aggression and they may actually need some input from case managers for helping them to work with this issue on a long-term basis. Teamwork and safety, of course, again, CUSIN, it's all very, very important. And we always have to make sure that we're safe and that the patient is safe. People should, staff that are working together should always be on the same page and should always be supporting each other when there is a crisis situation going on. And that we have to kind of realize too that behavior doesn't really occur in a vacuum, and that the milieu perhaps has to be looked at and look at what stressors are going on that the patients are dealing with, and just trying to see, especially if there's somebody on the unit that has like an antisocial personality disorder, they can just wreak havoc on the whole unit and make the whole milieu very stirred up, and that can be a precipitant for violence for other patients. The last thing that you really want to do, though, is to not intervene or to not address patients' behavior that is difficult or potentially violent on the unit, because truly the entire unit will feel that effects, and they're going to feel very unsafe if they see that staff are not intervening appropriately. So it is important for us to help the whole unit to really make sure that we deal with the milieu effect of patients' violent behavior and make sure that we assure patients of their physical and psychosocial safety. Very important part of the nursing role. So sometimes we have to use seclusion or restraints. So seclusion is putting somebody in a locked room. Restraints, you should know what restraints are. Usually we think of restraints as leather restraints, but of course there are other forms too. But for the most part, if we need to put somebody into restraints for a quick behavioral episode, usually they're 4-point leather restraints. So really, restraints and seclusion should be our last effort. We should always try other less restrictive efforts first, and it's only when the patient creates a risk of harm to themselves or others, and there's nothing else that you've tried is working or available, then possibly we should use seclusion or restraints. They shouldn't be a punishment. They shouldn't be for the convenience of the staff. Well, let's put this person in restraints so that we don't have to deal with them and they won't be bothering the milieu anymore. We really can't do that. It does make your life easier in some ways, because then you don't have to worry about that patient out in the milieu, but we can't do it for our convenience. And so we should have tried verbal interventions, offering medication, decreasing stimulation, possibly if a significant other can visit, if that would help the person to calm down, frequent observation, one-on-one. There's lots of things that we can try before we end up using seclusion and restraint. So again, seclusion is involuntary confinement alone in a room. Patient cannot leave. They are locked in. And again, restraints are any manual method, physical or mechanical device, material or equipment that restricts freedom of movement. So guidelines, well, of course, again, danger to themselves or others would be truly the only indication for use. Legal requirements, we do have to obtain a doctor's order. So we can't just, as nurses, we can't just make a decision to lock somebody in a room or use restraints without getting an appropriate order. Of course, in the heat of the situation, perhaps it's an acute situation that just came up and you don't have time to call the doctor ahead of time. And for safety, it wouldn't be a good idea to wait to call the doctor and to hear back from the doctor before you implement these measures if it's truly needed to maintain safety. But we do have to get that doctor's order. Everything has to be truly very clearly documented. So we should be documenting verbatim what the patient said in quotes, what their actions were. We can't just generalize and make it really vague. We have to be very specific about what the patient did, said, their exact behaviors. So a lot of observation. We can't just say patient agitated, put them in seclusion. That really doesn't cut the mustard at all. So from a legal standpoint, again, that documentation would not be adequate. So description, 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 and just as clear, and again, use quotations as often as you can. We have to use our clinical judgment and our assessment skills, and that should all be very clearly documented. The patient needs to be observed. Usually, I'll just say what we do on 1K. If a patient is in restraints or even seclusion, they do observe the patient on a one-to-one basis. So the observation, if they're in a locked room, the observation might be by a camera monitoring, somebody sitting at the desk watching the camera, or it could be somebody stationed outside their door and watching them through the window. So we do have to have that very careful observation going on when somebody is in a compromised situation like that. We also need to make sure that we discontinue the seclusion or restraint as soon as possible, that we don't just leave the patient there for hours on end because, again, it's convenient for us because we're too busy and we don't have the time to, properly care for that person. So we really have to be very careful of that. We should always be notifying their relatives also if the patient has given us permission to talk to their family. Let's see, what else do we need to talk about? One thing that's really important, we really have to think about their physical status also, in addition to their mental status. So again, that one-on-one observation, usually they have to be documented on every 15 minutes. We have to be monitoring their vital signs. We have to watch their range of motion. We have to watch for blood flow. So we have to make sure that they're not getting pressure ulcers and things are rubbing, so we don't want skin abrasion to happen. So we have to provide for nutrition, hydration, and elimination. And sometimes for elimination, we might have to take the patient out of restraint and escort them to the bathroom. If that patient still is iffy as far as maintaining their level of control and safety, it's very possible that we may have security assist us with that, but we really do have to pay attention to their physical care. Release procedure, usually we have to make sure the patient can follow directions and they can stay in control. Sometimes we terminate the restraints like one at a time. So we'll take out one arm and kind of see what they do with that arm. If they slug you, in the head, well, then they weren't quite ready to come out. You may have to put that arm back in. So if they do okay with that arm, they're not doing anything inappropriate, then maybe you'll release like one of their legs and then kind of see what they do with that. And then, release the other leg or the other arm, and then they're out of restraint. So we kind of tend to do it a little bit slowly just to make sure that the patient is maintaining control. And again, we always are going to debrief with that patient and just kind of make sure that they really understand what happened and why they needed to be restrained, and again, try to problem solve ways that they could avoid that in the future. So some restraint tips. So again, thinking about different ways that we can restrain people. So we can't physically hold a patient against their will. That's considered a restraint. 4 side rails up is a restraint, except if somebody has seizure precautions and they need padded side rails, then it's not considered a restraint. Keeping a patient in her room, his or her room, like by I've seen sometimes staff stand outside the patient's door and like prevent the patient from leaving because they're standing against the door. That is considered a restraint. Tucking sheets in so tightly a patient can't move is considered restraint. And you cannot get orders for seclusion or restraint PRN. It must be obtained, the order must be obtained at the time of the incident. Now, sometimes the doctor may not get back to you right away, so that's okay, but you clearly document in your nursing note that you contact what time you put the person into seclusion or restraint and what time you contacted the physician, so that at least you're covered there, therefore legally, as far as you did what you were supposed to do in dealing with this person in restraints or seclusion. You can't be blamed for the doctor maybe taking his or her time getting back to you because maybe they were in the middle of therapy, they were in the middle of an emergency or something. So, and that certainly is okay. We also should make sure as nurses that the doctor is indeed coming back and reassessing the patient. I believe at Sheboygan Memorial they come back. I think it's every hour they have to be reassessed. Again, the goal is truly to get that person out of restraints as quickly as is safely possible. So these restraint tips and guidelines are basically on a nice green table on page 512. Case study discussion. Mr. Oswald becomes violent and must be placed in restraints. What questions need to be asked after the incident? So again, debriefing. What happened? How did you feel? Was there anything? You always want to say, was there anything we could have done differently to help you? Get their input. That's really quite valuable as part of that debriefing process. Because maybe the patient will say, well, if somebody had just given me a glass of water when I asked for it, I would have been fine. Well, maybe not, but we have to take their their input into consideration, and maybe a different type of intervention would have been more helpful for them. So we can use that as a good learning experience for us and for the patient. So intervening in different settings. So sometimes we're caring for patients in general hospital settings who become violent. Many times these are patients, they have usually good coping skills, but maybe they're just overwhelmed. They just got a new diagnosis. They're in pain. They're suffering. They don't feel good. They're cold. They're too hot. They're nauseous. They just physically feel absolutely horrible. And being in the environment of the hospital that's not their comfortable home environment, all of that together can really just tip somebody over the edge. You might also see patients that just have marginal coping skills anyways, to begin with. They just aren't good copers, and they are certainly very likely in many different types of settings to exhibit some violent behavior. We also have to, again, think about caring for patients in inpatient psychiatric settings. And again, we're always monitoring patients carefully, documenting their potential for violence, and making sure that we're intervening in the milieu to make sure that everybody stays safe. And sometimes, again, people with cognitive deficits. So people in nursing homes that's kind of the setting where we mostly think of caring for patients with cognitive deficits. So sometimes that can be very challenging. But again, just some general principles are not to, again, be challenging the patient, and sometimes just going along with what they're saying and using distraction can be very helpful. So you don't ever, if a patient is agitated, they're in a wheelchair and they're saying, I'm getting out of this place, it is not helpful to say like, no, you're not, you're staying here, your daughter wants you here, I'm the nurse, I'm saying that you can't leave. Just to be, not to be super confrontational. And honestly, I heard a conversation like that when I used to do nursing home clinical. So we don't want to make people feel belittled and like we just don't understand what they're thinking. So if somebody is they have dementia, they're agitated, they're saying, I'm getting out of this place. It's helpful to say something like, oh, we've got some tea and cookies in the dining room. Come on, come over here with me. Let's go over here. So try to distract them a little bit. Or if they say, oh, I've got to get to work. Oh, where do you work? What type of work do you do? And try to get them on, even though it's not realistic. No, they're not working at this point in their life. But sometimes getting into a conversation about their work, then all of a sudden they're telling you about their life on the farm and their farmhouse and their family, and then all of a sudden they're calmed down. So there are techniques that we can use with when we care for patients with cognitive deficits. Sometimes some orientation aids can also be very helpful in working with patients that have dementia issues, calendars, clocks, things like that. But again, there's a nice paragraph on page 515 that just really talks about how sometimes people just don't respond very well to reality orientation that's providing them the correct information about what's going on. So, you can't say to somebody, or it's not helpful to say to some patients, nope, you don't live on the farm anymore, you're in a nursing home now. That would just not be very helpful for some patients. There are patients that may become very agitated with that. So we kind of have to enter into their reality and kind of deal with them that way. Audience response question. Finally, Mr. Oswald is restrained as his nurse. What's your first priority? Debrief the patient, ensure the patient's safety, administer a sedating medication, and obtain an order from the healthcare provider. So I'm hoping you're thinking, it sounds like a little bit of a trick question, but actually B is the first priority. So that would be the most important thing, is to make sure the patient is safe. And then you want to get that order. So let's think about this as a what you would do in what order. So first, you're going to ensure the patient's safety. Next, you are probably going to get an order from the healthcare provider, or at least give them a call. And then you might want to think about giving them a medication. Debriefing would really be the last thing that you're going to do, because you're not going to debrief them when they're in seclusion or restraints. You're going to wait until they're calmer and they're able to have a conversation about what went on. So last audience response question, which patient behavior is a criterion for mechanical restraint? Screaming profanities, assaulting a staff person, refusing a medication dose, or throwing a pillow at another patient. So again, I'm hoping that you picked really truly the only one that is a criterion for mechanical restraint would be assaulting a staff person, because that's a direct danger to that staff person. Screaming profanities, it's not good. It's a signal something worse might happen, but it is in and of itself alone, it is not a reason to use restraints. Refusing a medication dose, people have a right to refuse unless it is court ordered. Throwing a pillow, you're going to pay attention to that because it's not good, but a pillow is soft. It's not likely to hurt anybody. So that is the end of Learning Plan 5.